Topic is on angioid streak. Angioid streak represents the peripapillary radial breaks in a calcified, thickened and brittle Brooks membrane. It's little bit of history. 1889, Doyne first described as a irregular jagged lines in a patient with blunt trauma, and the patient had other eye had a similar characteristic location around the optic disc. An independent case report was published by a Planch in 1891 as a pigmented striae. The Herman and Knapp introduced the term of angioid streaks in 1892 due to the similarity of the retinal vessels. So clinical characteristics, it is a jagged irregular line with serrated margin originating from the optic disc, and similar variable, it is similar to the retinal vessels with the caliber of 50 to 500 microns. It is subretinal in location, and its streaks may interconnect and usually form a ring around the optic disc. It is grey, black or red or pink in color depending upon the race of the patient, and macula may be involved, and there will be abrupt tapering of the end away from the optic disc. Angioid streaks can be idiopathic or systemically associated. The most common is Pseudoxanthoma elasticum. I'll elaborate it a little later. The next is Paget's disease of the bone. It is an disease of the osteoclast that cause increased rate of the bone remodeling, thereby deposition of the calcium in the Brooks membrane. And others are hemoglobinopathies like sickle cell anemia or microspherocytosis can also cause angioid streaks. Ehlers-Danlos syndrome, it is least commonly associated at around 1 to 2%. The mnemonic is like TEPSI, like Pseudoxanthoma elasticum, Ehlers-Danlos, Paget, sickle cell and idiopathic. Pathophysiology is a combination of elastic degeneration and iron deposition from the hemolysis in case of sickle cell anemia or microspherocytosis. It impairs the nutrition of the Brooks membrane, and it also contributes to the membrane fragility. The orientation of the angioid streaks related to the force of line due to pull of intrinsic and extrinsic muscles of the eye with the fixed optic nerve. When full thickness breaks occurs, there is a disruption of the choriocapillaries. It can cause atrophy of RP and loss of overlying photoreceptor cells. So in case of PXE and Paget's disease, there will be a deposition of the calcium in the elastin layer in the Brooks membrane, and in case of sickle cell disease, there will be a deposition of iron, and also it causes oxidative damage resulting from hypoxia, which results in fragility of the Brooks membrane. Histopathology, like there will be a deterioration and fragmentation of the elastic lamina within the midsegment of the Brooks membrane. That is the characteristics of the angioid streaks. There will be a granulomatous deposition in the elastic lamina, the absence of choriocapillaries beneath the streak, and then thinning of discoloration of the RPE. They also demonstrate the calcium deposition in case of Pseudoxanthoma elasticum. So causes for the visual loss is like a trivial trauma can lead to the rupture of choroid and can lead to submacular hemorrhage and visual loss. A break in the integrity of the Brooks membrane can cause the choroidal neovascularization, and if it is a foveal involving, it can cause RP loss and vision threatens, like visual loss. So mostly it is asymptomatic. Patient develops symptoms only when they develop the type 2 CNVM or the active CNVM or like scarred CNVM, and like central visual field get affected and the loss of color perception also. These are some signs of angioid streaks. Pudea orange appearance. It is also known as the orange choroidal reflex. There is a central calcified zone and the peripheral uncalcified Brooks membrane zone. So within the calcified area, the Brooks membrane break will be seen. That is the angioid streaks. And the cracked eggshell appearance, that is the opacification of the Brooks membrane due to the deposition of the calcium. And the comet tail appearance, that there are like a small multiple RP outer retinal atrophy, like excrescence of RP that we seen mostly in the mid-peripheral region. And another is subretinal or submacular hemorrhage following trauma, and pattern dystrophies like Pseudoxanthoma elasticum little bit, like this an autosomal recessive disease is caused by defect in the ABCC6 gene in the chromosome 6 that is mainly produced by the denoted in the hepatocyte. It needed for ATP transport. Like a mutation in this will lead to reduction in the inorganic pyrophosphate that is more needed for controlling the ectopic calcification. So the reduction in the IP, like inorganic pyrophosphate, result in ectopic calcification. That is the main pathogenesis in the pseudoxanthoma elasticum. So the criteria is like two major skin criteria and ocular criteria, and two mutation should be there in ABC6. Skin criteria is like chicken plucked chicken skin appearance in the neck. That is a papules on the neck extending to the axilla, chest, abdomen, and flexural regions. This is the typical appearance of pseudoxanthoma elasticum. And the histopathological shows the calcification and the pleomorphic elastic fibers in the dermis region. And in eye, there is a criteria is like more than one angioid sticks of more than one disc diameter in length, and also along with a pseudo-orange appearance. Minor diagnostic criteria is like histopathology changes with the skin, along with the one allele mutation ABC6 gene. Here the pseudo-orange appearance is seen more in the infrared reflectance, and the top one showing a comet tail appearance. In fundus fluorescent angiography, the early phase it will be hyperfluorescence because of the window defect, and there is a atrophy of the RP, and there is a separation of underlying choriocapillaries. In the late FA phase, there will be a staining of the edges of the streaks along the, and if it is like a active CNVM, we can see the leak in the late phase of the angiogram. ICGA, it is a gold standard, and it shows a track-like streak marked by a hyperfluorescent center with the hypofluorescent edges, and pseudo-orange appearance also be seen in the mid-peripheral region in the ICG. And OCT and OCTA, we can make out a focal break in the Brooks membrane. Like in ultrasound, if it is like pseudoxanthoma elasticum, 25% may be associated with the optic nerve head drusen, so can be seen in the ultrasound B scan. There's a different patterns of macular atrophy they are identified in the angioid streaks. First is RP rip, and that will be characterized by rounded angular borders. And second is multilobular atrophy. They are similar to geographical atrophy. And third is ill-defined. The RP rips are closely associated with the macular neovascularization, and multilobular and ill-defined are less related to macular neovascularization. So differential diagnosis like mainly normal retinal vessels and subretinal tracts due to ophthalmomyiasis. It is a larval infection, and subretinal bands in long-standing RD, and the peripheral punched out scars like comet tail may presumed ocular histoplasmosis syndrome, and choroidal rupture in case of trauma. Myopic lacuate cracks. These are the breaks in the RP, Brooks, and choriocapillaries. Three things will be affected, and mostly in the posterior pole, and it's seen in high myope, and it is caused by the stretching of cords with increasing axial length. And reticular dystrophy of RP, these are like fishnet with knot appearance, like deposition of RP pigments, and they are located mostly in the posterior pole, and they are in the circular format, and due to the mutation of peripherin and RDS gene. This article showing in mostly angioid stick type 1 predominates. Even though type 1 predominates, it is like more correlates with a substantial visual improvement as like in type 2. So close observation is needed in case of angioid stick associated with CNVM. There are stages stage 0 is dark angioid stick. There is only bare dehiscence of Brooks membrane, but in the OCT and FFA there will be like hyporeflectivity will be seen. In stage 1 there will be a staining of angioid streaks. There will be a break in the Brooks membrane with hyperreflectivity will be seen on the OCT and in the FFA. And stage 2 is type 1 CNVM, and stage 3 is type 2 CNVM. These are the stages, like stage 0 there will be a trivial Brooks membrane defect. In stage 1 will be like the stain taking in the FFA, and stage 2 is type 1 sub RP, and stage 3 is subretinal CNVM. These are the elaboration. Treatment mainly for the exudative type choroidal neovascular membrane is like anti-VEGF, and PDT is outdated now. Mostly like we should be encourage the patient to wear a rigid eye protection to prevent any trivial trauma to cause choroidal rupture and secondary bleeds and visual loss. So I'm going to discuss cases like case 1, a 44-year-old male presented with defective vision with the vision in right eye 1/60 and near vision N36 and left eye 6/9 N6, and he had history of multiple intravitreal anti-VEGF injection. In outside diagnosed as a scarred CNVM. On examination he had a plug chicken appearance skin in the neck and some elbow flexural area. So he was found to have a pseudoxanthoma elasticum with scarred CNVM in the right eye. And this is the skin, like nodular skin appearance. In the right eye showing a scarred CNVM with the angioid streak. This OCT showing a break in the Brooks and RP complex in the peripapillary region. And this is showing a mid-peripheral comet tail, like the other RP excrescence seen in the pseudoxanthoma elasticum with angioid streaks. The autofluorescence image showing a scarred CNVM with the angioid streaks. The right eye OCTA showing a large, like a tangled vessel is seen submacular region, and irregular hyperreflective membrane subretinally it is seen in the parafoveal region with skytic retina overlying that. Left eye showing a foveal thinning with parafoveal fibrous subretinal hyperreflective membrane. This right eye OCTA picture showing a large submacular tangled vessels with OCT showing a subretinal hyperreflective membrane parafoveal region with overlying skytic retina. This is the outer retinal tubulation. Skytic retina.
You said outer retinal tubulation?
No, sir.
Oh, no.
Skytic
Not
retina
in that.
overlying.
Not in that view. There is another view where you can see the ORT, but not in that view. You showed us an article which is commonly type 2 more often than type 1. Is it shared by every investigator, this particular thing? Because whatever I have seen is mostly type 2s.
Is the more common variety. That article
shows only type 1.
Why you chose specifically that article to tell us a information?
Type 2 was common, but in that article only it showed type 1.
Yeah, so you wanted to show us only that article to
confuse
us?
In that they told like even though if it is type 1, it needs a close watch-up because it will act like a exudative AMD, like exudative CNV.
If it is a type 2 fine, but type 1 fine, but type 2 I will not wait. I will treat as early as possible.
They concluded like this, even if it is type 1 needs a close watch-up because it can...
Type 1 even in AMD we make a close watch. No, type 1 is sub-RP. It is not bound to exude fast. But type 2, whether it is myopic, whether it is peripapillary, CNV because of choroiditis, whether it's due to angioid, we never wait. The earliest sign of any SHREM that you can see on the OCT or hemorrhage, we treat. We don't wait for the patient to develop, otherwise they will lose whatever site they have. Very quick scarring. So you took the wrong impression from that article. I shared so many MRD numbers. I haven't seen how relentlessly progressive it is, the disease. Once the CNVM starts, it's progressive every time. You have to keep a very close watch. Once it starts, the CNVM starts developing, it becomes active on and off. So you treat as soon as the patient starts complaining. Very similar to myopic CNVM.
Left eye OCTA picture shows a tangled vessel in the ORCC complex and OCT showing us subretinal hyperreflective membrane parafoveally with the cystic spaces overlying the retina. He was advised home Amsler regular monitoring and need for anti-VEGF in future in case of active CNVM. So case 2, 45-year-old male presented with defective vision in the left eye. He also had a plug cheek and skin appearance. Elsewhere diagnosed as angioid streak with CNVM and post 2 intravitreal injection was given. You know, vision is 6/6 N6 in both eyes.
Fathima, what is the scientific name for plug chicken? You used it in your...
No, papillonodular lesion.
So use that instead of plug chicken. Don't keep plucking the chicken, just tell us. he has that kind of picture.
Nodular
It's
papilla.
good to use scientific terms rather than colloquial terms.
The fundus photo showing angioid streaks radiating peripapillarly and also the comet tail appearance in the mid-peripheral region. It's seen in the both the eyes. These are the angioid streaks and these are comet tail. The tail towards optic nerve head. The same photo showing little bit clearer images of angioid streaks. This is the autofluorescence image showing angioid streaks peripapillary region. The OCT, the right eye showing up, there is a pigment epithelial detachment under the fovea. There is no network was seen in the OCTA. Choriocapillary, this is also choriocapillary slab. And fovea appears compact. These are the fibrovascular PEDs noted under subfoveal region. On the left eye shows a subretinal fluid with fibrovascular PVD subfoveally with the OCTA showing a tangled vessel appearance in the ORCC complex, and it was suggestive of active CNVM and was advised anti-VEGF injection in the left eye. This is another case with a 45-year-old female presented with defective vision in the right eye for 15 days following a trivial trauma. On questioning, she had a reticular pattern of nodular-papillar lesion in the neck region. So she told it was like had it since birth, diagnosed as a pseudoxanthoma elasticum, and he denied any known systemic illness. Vision in the right eye was 636 and N12, and the left eye was 66 N6. This is the nodular papillar lesion. The fundus showing pre-retinal hemorrhages, subretinal hemorrhages in the posterior pole, along with the angioid streaks shown in the right eye. Also, this is the angioid streak with the subretinal heme following a trivial trauma. The left eye showed like subretinal peripapillary fibrosis bands. In the left eye angiogram, it shows a staining of this fibrous tissue in the angiography, and OCT was compact and there was no CNVM. In the right eye, in the angiography showed a staining of angioid streak with the subretinal bleeds were seen, and there will be in the late phase it shows active CNVM. This is the hyperfluorescent staining of the subretinal fibrous tissue. She had an angioid streak secondary to pseudoxanthoma elasticum in both the eyes with the extrafoveal choroidal neovascular membrane in the right eye. So was advised anti-VEGF injection. So this is the post anti-VEGF injection. There is a resolution of the subretinal heme. So this is the choriocapillary slab shows these are multiple round hypo flow deficit area or like RP atrophy, like all these round.
No, you're using so many different things. RP atrophy in a slab, you cannot talk about RP atrophy.
This black
This is an
spots.
angiography.
RP atrophy is not seen in the choriocapillary slab.
But
This is a choriocapillary slab, not the one you showed earlier. That was large capillary vessels. I hope you have noticed the difference. Now choriocapillary is a small. We all learned that in MBBS. Even in biology class, capillary is a small. That is big. Okay? So when you see these small little, this is typical of a choriocapillary slab. This will flow defects because of loss of choriocapillaries, not because of RP. RP is different, choriocapillaries is different. In between is the Briggs membrane. Okay. If you have any extreme trauma, because the hemorrhage is so extended,